And for this lecture, we have none other than Dr. Alexander Gubin, who is the director of the Russian Ilizarov Institute himself, to address us. A few words about him. He's a pediatric surgeon. He has got special interest in pediatric cervical spine. He was working in Children's Hospital at St. Petersburg, and before he took over as the director of the Ilizarov Institute. He is the AO Spine Educational Officer for Russia, and he is also the chief editor of the Ilizarov Journal of Clinical and Experimental Orthopedics, which is previously the Genij Orthopedy, the most authoritative journal in the Russian language on Ilizarov. And maybe I should add a personal note of, it would be very appropriate for me to add a personal note of gratitude and acknowledgement to Dr. Gubin. I know that he is dedicated to spreading the Ilizarov technique all over the world. I have experienced that myself as a fellow in that esteemed institute for a period of about 6 months. All fellows are directly under Dr. Gubin, and he takes care of you so much. Whenever, whatever you want, you can just fix an appointment and walk into his office, and whatever you ask will be done by Dr. Gubin. So that is the amount of gracious support and encouragement he gives to foreign fellows. And I still remember the words he said to me on the first day when I met him in his office. He said, "This is a treasure. Take from here as much as you can, learn as much as you can. Think about them, go back, compare it with what you are doing." And he was not dogmatic to say, forget whatever you have learned, do this. He said, compare it with whatever you are doing now. Think and try to mix whatever you are doing and try to add whatever you are learning from here. Mix and match so that you give the best results to the patient. Those words are still fresh in my mind, sir. I would really thank you for all the encouragement and support you gave me during the period of the fellowship in Russia, and I invite you for the talk, Ilizarov, Past, Present, and Future. And I take it a great privilege to introduce my teacher to this august gathering.
Thank you, Dr.
Thank you so much.
For these kind words. Do you hear me well? So maybe I will stand here and not go to this. Is it okay? Yeah, to be and to look at you in a good position. It's great pleasure for me to be here in India. First of all, because it's a wonderful hospital and a wonderful idea of charity. And it's so important, this charity is so important now in this very, very hard age for all world and Russia too. And especially for Ilizarov method, because now it's so hard to organize Ilizarov techniques, Ilizarov treatment in hospital all over the world because of economical issues, because of social issues, and you can do this here in this wonderful building, in this wonderful institution. So charity is very important. So what's the main ideas that I want to share with you today? What I want to tell you about Ilizarov. So of course we'll see a lot of different techniques, but when we are speaking about techniques, at first we must understand the main ideas, the main principles, and what is more important, what we used to say about Ilizarov is his philosophy, because now we use this word philosophy more and more. It's not only technology, it's not only method, it's not only way of doing something. It's a great philosophy which can be very useful in different kind of surgeries, in different kind of approaches, in science and in practical medicine. So what's about Ilizarov? You see this picture, it's favorite picture like charge. And there are many, many favorite orthopedics here. But one is not looking at this nail. One is standing in the corner, and this is Ilizarov. You see, the author of this painting put Ilizarov not in the center and make him look at us, not at the nail, because he thinks different. He has his own way of thinking, another way of thinking. That's why he became another. That's why he became successful, because he thinks different. And he had very different life for Soviet, for Russian, for Soviet in this period guy, because he really traveled around the world and shared his technology, his ideas to the world. And it was so unusual for Soviet period in this time. And we really had a lot of people, some of these people are sitting here in our center for all this period with Ilizarov, and now too. And it was absolutely not usual for the closed Russia, for closed Soviet Union country. That's why he had so many friends all over the world. That's why he really have very different life. And of course, he do different. He do different, that's why he was so successful and so unusual. That's why he had so many enemies. But from another side, he earned so many friends and so many colleagues in the future. And we call these people Ilizarov-minded people. Many of doctors who are sitting here, they are Ilizarov-minded. So we used to say that some doctors can play puzzles, you know, puzzles, and usually the modern technologies are like puzzles. So we must do this, nothing else, don't touch this. And speaking about Ilizarov, the technology of control of all period of treatment. So you can do your own way in every case. You just like playing chess. Not puzzle, but chess. And you must be ready for really long relations with your patient. So it's very unusual too in a modern world, when we try to make some quick surgery and say goodbye, and we don't want to see you. But when we are treating this very hard kind of patients, with many difficulties, with many complications as usually, or after a period of complications, we need long relations. And to control all this period, we need very good method to control. So Ilizarov method, it's a method of control. And people who are working with Ilizarov and who have Ilizarov in their mind, they are Ilizarov-minded people. And they usually rule busters because they want to make their own rules. They want to make their own apparatus, their own frame. They want to introduce something new, details in the apparatus, some new details in the technology. It's so usual. Because we can put the system of control out of the body. And when we put it out of the body, we have enough space. We have enough opportunity to make our right actions. Because when we are inside the body, we have too much space for free actions. And when we're out of the body, we have a lot of space for actions. This is the idea, how to create this space of actions. What's another interesting thing, and very, very special for now, for our age of evidence medicine, but what was not so really usual for Soviet period and for Russian surgeons. So you know that we are not very well citated in the world, because we use Russian language, not English language, so we didn't like to share all this data, all this material in English, unfortunately. But Ilizarov did. So he was really, really smart in this position. So he published most of his articles and his books in English, not in Russian. And you see that he is one of the most citated author in orthopedics now. So he has 3,328 citations in Scopus, and more than 700 only for last 3 years. So he's still active. Of course, he is still active. So it's absolutely fantastic for Soviet doctor, for Russian doctor, to have such good evidence.
But if we look what is most important of his articles, it's the article about Ilizarov law, the article about distraction osteogenesis, tension stress effect. So on this Ilizarov law, a lot of techniques, many techniques were based. And now we use different approaches. We use different frames. We use internal fixators, nail which can lengthen your bone, plates. We can do the different techniques. But anyway, all these techniques are based on Ilizarov law. This is the philosophy of Ilizarov: control and Ilizarov law. So we published this article with Dmitry Borzunov 2 years ago in International Orthopedics, and we tried to point on the most important things in Ilizarov techniques now in the future. And we just make it as possible as it can be. So we just pointed in a few 4 words, really. It's barrier, it's control, it's stimulation, and it's comfort. This is the mainstream or the curriculum for our future research and work. What is barrier? We know that...
On किया है ना? Off कर देना. When I start.
No, sir, we'll wait for some 10 minutes. The lecture is going on.
So you know that Ilizarov technique is very important in osteomyelitis treatment. And it's really like a parachute technology, like a parachute procedure in many, many complications. But we have one problem. We have implant which is going outside, inside, then again outside. So we usually have contact with bacteria. So it's a big problem. It's a problem of barrier. How to organize good barrier against microbes. How to treat osteomyelitis and pin site infection. So pin site infection is a very important thing in which we must have some success in the future. I hope so. The barrier idea is very important in other technologies too. So now we are going to make these procedures of osseointegration, and they have the same principles. We have implant inside, we have implant outside in amputees. But we have the same problem, the problem of pin site infection, how to protect implant from infection. Generally, we have the same problem in every implant, how to make a barrier against infection. So it's a great task in which we must go further. Another aim is control. Control is a very understandable thing in an apparatus treatment. Yes, we must really make control all period of treatment. And it's quite simple, understandable in such cases. What is the future? The future of control is, first of all, it's new system which will be automated. It's new kind of keg supports. It's new lengthening nails or some internal systems. It's new combination of X-fix and in-fix to make treatment more comfortable and shorter in the hospital stage. And of course, it's new biomechanically approved hinges in arthrodistractive surgery, because we have a lot of problems in these ideas, with these ideas. And what is very interesting for Indians, because India is a really intellectual country in computer technologies. We must do new smart electronic controls and internet control for treatment of these people, because if we'll have autodistractive systems, if we'll have nailing for lengthening, we must keep in mind that we need new smart electronic control for all these features. And I think that from India's side, it will be great support and help in this field. What's about simulation? Simulation is based on Ilizarov law, the law of distractive osteogenesis. What is the future of stimulation? The future of stimulation is new coated implants to make healing more quick and safe. It's new electrostimulation because we don't have any real evidence about electrostimulation now, but maybe it will be in the future. It's new bone morphogenetic protein and combinations of bone morphogenetic proteins and other technologies. And it's new STEM technologies. This is all about stimulation. But when we are thinking about stimulation, we must keep in mind malignization, cancer. So it's very important to find the right balance between stimulation and harm, because it's very important not to hurt anyone. What about comfort? Our treatment must be comfortable for patients' families, and for doctors too. And it is a very important issue. We really sometimes, as we are Russians, we don't think about comfort a lot, unfortunately. So, but we need comfort in this real world, because people are really looking around, and they need to go to their work very quickly. They need to be with their families, with their everyday activities. And how to organize this using external frames, this long period of lengthening and reconstruction, it's a great issue. How to organize all this rehabilitation period. It's the issue of comfort. So we need new patients-friendly devices. We need new doctors-friendly devices. And we need evidence-based rehabilitation programs. We don't have good rehabilitation programs for our patients with limb lengthening reconstructions. We need to get them on the new evidence-based. So we need new scores, like Scoliosis Research Societies or OVS3 index, disability index. They must be the same, but we need our scores to really make evidence and to create more comfortable environment for our patients. So we'll have 2 meetings in the next year, because next year is announced as Ilizarov year in our region, in Kurgan region, because it will be 95th anniversary of Ilizarov, 65th anniversary of Ilizarov method, and 45th anniversary of Ilizarov Center. So in our region, 16 will be announced as an Ilizarov year. The first big conference, which will be held in Russia, it will be in St. Petersburg. And we are Ilizarov Center. We are not in St. Petersburg, but we will organize this meeting. So it's a very beautiful city, you know, that with, in May it will be white nights. So it will be no night at all, maybe for 2 hours, a little bit, not real night. So wonderful, wonderful time to go. And it will be devoted mostly to rehabilitation and orthotherapy. So a lot of issues which were discussed in my lecture today. But the main meeting will be in Kurgan, of course. It will be in June. It will be 3 days, and it will be made with Texas Scottish Rite Hospital, a hospital which is very active in Ilizarov technology in the United States. So there will be a great amount of participants from all over the world in this meeting, and you are welcome. You are welcome. You can find all additional information on our website, which is Ilizarov.ru. Thank you very much. It's a great pleasure to be with you. If you have any questions about Ilizarov technology or philosophy, we can just discuss.
Thank you very much, sir, for your conceptual talk on Ilizarov and how you see the future of Ilizarov. As we are relaying with the live surgery, any questions on this may be addressed now.
Okay. Thank you.
Yeah, we are ready for the live surgery from here. He is a person who can speak about the philosophy of Ilizarov and the principles of Ilizarov for hours, and he is an excellent teacher in the subject. He is one of the persons who is really into Ilizarov and who has really understood the philosophy and the principles that guide it, and it's a good resource for us to have Dr. Dmitry Bozunov here. He may need some help in translation, which Dr. Gubin, Dr. Agarwal, Dr. Bari, and Dr. Harish can help. Welcome you, sir, for your lecture.
Dear colleagues, Oh. Excuse me. One moment. Okay. Dear colleagues, currently most of the authors consider two methods of bone transport to be the most effective and alternative ones. Non-free bone plastics by Ilizarov and grafting by a complex of tissues with preserved vascularization, including free outer grafts into the defect. Common in the technologies is maintaining vascular connections with soft tissues of the segment adequate blood supply, resistant to infection and capable of complete organotypic remodeling. Filling in of post-resection radial defect formed after resection of osteoblastoclastoma by a free fibula outer graft with the nosus arterial shunting. Advantages and disadvantages of free vascularized bone outer grafting. The first experimental model for filling in post-resection tibial defect by a lengthening of the proximal fragment. True bone defect is any loss of bone tissue and total amount of interfragmental diastasis and anatomical shortening of the segment. Defect classification, defect pseudarthrosis, defect diastasis. In Ilizarov transosseous osteosynthesis adaptation of the docking site, closed and open coaptation of the bone fragments, and maintaining compression between fragments depend on a complex of factors. Congruent ends of bone fragment, close adaptation. Non-congruent ends of bone fragments, open adaptation. There are different shapes of end of bone fragments. The diagram of creating a longitudinal axial compression. Clinical example. The plate was removed, the compression between the M fragments. Close consolidation. Techniques for close consolidation of end of bone fragments creating side-to-side compression with a long connecting plate. Clinical example, post-traumatic pseudarthrosis of tibia, intermediary locking nail. Reosteosynthesis, the nail was removed. The close remaining of pseudarthrosis, the side-to-side compression of pseudarthrosis with a Ilizarov frame. The view of the frame of the side-to-side compression. Techniques for close consolidation of end of bone fragments creating side-to-side compression by tensioning vise. Clinical example. Post-traumatic pseudarthrosis of the side-to-side compression of the pseudarthrosis with the vise. The vise spins have form like olive. Clinical result. The use of technologies depending on the mobility of fragments. The types of osteogenesis. The use of techniques depending on the types of osteogenesis. You can see the etiology of pseudarthrosis and classification by evolvent segment. And in terms of infection. The main of treatment and rehabilitation is a restoration of anatomical and functional integrity of the limb. The system of reconstructive and restorative treatment of the patient with the long bone defects by Ilizarov is based on the following principles to rehabilitation approach. Fragments lengthening, healing at the docking site, tibular-fibula synostosis, and gradual tension of interfragmental tissues with a regenerate formation. All technologies of transosseous osteosynthesis have fundamental theoretical grounds. Monolocal distraction compression osteosynthesis. The technique of filling the defect by lengthening of the fragments with formation of the distraction and regenerate is presented by bifocal osteosynthesis in modeling conditions of bone transport for the amount of 20% of the original length of tibia. The bone hearing of the distraction or regenerate at the docking site was observed by the 90th day of fixation. Multi-level lengthening of the proximal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening of the proximal fragment. In experiment is post-resection tibial defect of the same amount by multi-level lengthening of the fragment. Opposite fragments lengthening, the duration of osteosynthesis was decreased by 1.5, 1.7 times. The process of distraction osteogenesis in polyfocal bone transport, we characterize it by high level of endostele and periostele bone formation. Multi-level lengthening of the distal tibial fragment. Polylocal distraction compression osteosynthesis, multi-level lengthening of the distal fragment. Filling in tibial defects by lengthening of the both tibial fragments. Polylocal transosseous osteosynthesis, lengthening of fragments towards each other. Tibia-fibula synostosis is presented by the method of mono or polyfocal bypass synostosis and was characterized by a high level of the plasticity and reparative formation of the bone tissue. All experimentally tested technologies of feeding in the bone defects and pseudarthrosis are currently widely introduced into clinical practice. Distribution of pseudarthrosis and defect by localization is presented on the slide. Schemes of the monolocal transosseous osteosynthesis. Monolocal compression distraction osteosynthesis for pseudarthrosis with inguration. Placement of handles of correction of stiff angular deformity in pseudarthrosis. Patient with diagnosis post-traumatic stiff pseudarthrosis defect pseudarthrosis of the tibial bones with varus and anti-curvature deformity. Duration of the disease is 3 years. Transosseous osteosynthesis of the tibial bones using Ilizarov frame, osteotomy of fibula, and menton removal were performed. Distraction was produced as the traction junctions placed on the post-medial tibia. Full restoration of the anatomical segment integrity was obtained. Patient with M-failed joint, open adaptation of fragments, compression of the docking site. Treatment result. Bilocal transosseous osteosynthesis. Patients with diaphyseal ulnar defect. Defect was filled in due to proximal fragment lengthening. There was an open fragment adaptation of the docking site. Patient with defect of tibial bones after gunshot wound, arteriogram. Defect was filled in due to distal fragment lengthening with overlap of bone fragment ends. Foot equinus was liquidated. There was an open fibula fragment adaptation. The treatment result. 1 year's follow-up. Polylocal osteosynthesis. Patient with the following diagnosis: 15 centimeters post-traumatic diastasis defect of the right tibial bone. The defect was filled consecutively at 2 levels by lengthening of proximal and opposite distal fragment of tibial bone. 1 year's follow-up. Patient with post-traumatic tibial defect. The defect was filled due to tibial fragments lengthening towards each other. 2 distraction regenerates. The open fragment adaptation. The treatment result. Patient with post-traumatic tibial defect. The was result of proximal fragment lengthening. Ischemic regenerate. The defect was filled in due to tibial fragment lengthening towards each other. Ischemic regenerate was compressed. 3 destruction regenerates. The open fragment adaptation. The treatment result. Patient with post-traumatic ulnar defect, failed joint of radial bone, the scheme of osteosynthesis. The ulnar defect was filled due to consistent multi-level lengthening. The open ends fragment adaptation. The treatment result. Patient with post-traumatic tibial defect. The tibial defect was filled due to consistent multi-level lengthening. The fragments are congruent. The closed ends fragment adaptation. The treatment result. Technologies of tibia fibula synostosis. Patient 3 years old, diagnosis with sequelae of gematogenesis osteomyelitis, subtotal defect of tibial diaphysis. Reconstruction of tibial by transporting fibula. Short-term follow-up. Follow-up after 6 months. 6 months, this slide. We use non-conventional technologies, decisions of the filling in the bone defects and correction of pseudarthrosis using transosseous osteosynthesis. Post-traumatic patellar failed joint, the open adaptation, transosseous osteosynthesis. The treatment result. The scheme of the transosseous osteosynthesis of the clavicular failed joint. Patient with clavicular failed joint. The open adaptation of the fragment ends. Transosseous osteosynthesis is made by the scheme. The treatment result. The other patient with clavicular failed joint, the open adaptation of the fragment ends. Transosseous osteosynthesis. The treatment result. Patient with clavicular defect, free bone plastics by fibula. Transosseous osteosynthesis is made by the scheme. Fixation 4 months. Treatment result. Patient 6 years old, diagnosis with bone cyst and pathological fracture. Stages transosseous and intramedullary osteosynthesis usually twice with hydroxyapatitis. Transosseous osteosynthesis of the humeral bone, the cyst compression. There was no recurrence of the disease 4 years after treatment. Osteogenesis sarcoma of the tibia. Post-traumatic defect was filled by 1 level lengthening of the distal fragment. The treatment result. Adamantinoma of the right tibia, the scheme of the osteosynthesis. Segmental defect of the tibial diaphysis was filled in by lengthening of the fragments towards each other. Osteoblastoclastoma, the scheme of the osteosynthesis. Post resection defect was viewed in a 3-level lengthening of the proximal tibial fragment. The treatment result. Osteoblastoma of proximal metaphysis of the right tibia. The scheme of the osteosynthesis. Free bone plastics, transosseous osteosynthesis. The treatment result. Patient 56 years old, diagnosed with post-traumatic stiff failed joint of femur. Deformity was corrected during 30 days. Intermediary nail osteosynthesis. Patient with round full femur fracture. Shortening is 7 centimeters. The femur osteotomy. Lengthening is 2 millimeters a day. Intermediary nail osteosynthesis. Patients 24 years old, diagnosed post-traumatic pseudoarthrosis of femur. Shortening is 40 centimeters, intermediary locking nail. Reosteosynthesis of the femoral bind nail, the closed remaining of pseudoarthrosis, the compression of pseudoarthrosis with Ilizarov frame, the lengthening of the femur. Distraction 41 days, fixation 60 days. Short-term follow-up. The Ilizarov apparatus is the removal, distal locking rod. Patient in Amsterdam in 3 years after treatment. Ilizarov method is highly effective in treatment of patients with long bone defects. The disadvantages of the method of the long terms of treatment and patient discomfort. The association of the method of transosseous osteosynthesis with intermediary nailing was being seen a good perspective. Thank you for attention.
So much, sir, for those amazing cases and wonderful cases. Any questions will be addressed now, and we will go ahead with the limb lengthening session.
Extramedullary fixation or intramedullary splinting during or just immediately after he finishes lengthening to decrease the amount of time spent on the frame.
The question to Dr. Bozunov is, once he gets the bone transport done, once he compensates the defect, does he just continue with the fixator, or does he use any intramedullary fixation so that duration can be reduced?
Вот тогда мне помогите просто, если я понял.
First of all, we do combination if we need a short period and patient demands a short period of treatment. And we use elongation on the nail already. So you can do this in one session. Она спросила, в какой момент забиваете гвоздь? Я понимаю. Okay, so.
May I ask a question?
Any strategy to prevent a refracture after Ilizarov removal in huge defects?
Есть ли какая-то тактика по профилактике переломов при больших дефектах после удаления аппарата?
Эта проблема делается в том, что наличие пружинной фиксации подразумевает отношение отсутствия риска перелома. Когда лечение с помощью аппарата, вы должны понимать, что у вас опасный период, особенно первые 3-4 месяца. Поэтому очень аккуратно техника, массаж,
Nailing is the best way to for prophylactic of fractures after frame removal. So if you don't have a nail, you must don't be so extensive with rehabilitation, with physiotherapy in the first 3-4 months after surgery and after frame removal.
In polylocal osteosynthesis, where you have multiple segments transported, how easy it is to introduce a nail? Will there be a well-formed medullary canal in the center so that you can pass a nail, or is it technically very demanding? Maybe after a limb lengthening we can understand, but with so many segments, with the pseudarthrosis united there, maybe some sclerosis there, and 2-3 levels of bone transport, is it easy to pass a nail?
Когда у вас много выполнения эффекта, потом вставлять будете, насколько тяжело попасть в консервацию? Ну, изначально необходимо ремонт для определения стержня.
One question.
Достаточно свободно. Нужно проходить.
So the rimming is mandatory in all these cases, so good rimming.
Is it possible?
Yeah, it's possible.
Madam has a question. That is what their experience is. After the consolidation of the regenerate, instead of putting a nail, they put a locked plate to protect the regenerate. So she wants to know Dr. Bozanov's opinion on it. What is the role of a locking plate in protecting the regenerate to prevent refraction?
Ваше мнение о пластине с боковой стабильностью, как тоже система превентивная?
Maybe that is technically easier than a nail.
Like many of you young surgeons here, I was completely enamored by the possibilities of the Ilizarov technique when I saw Professor Ilizarov and his colleagues perform these wonderful feats of lengthening. The act of limb lengthening has the science, the craft, the art, and the surgery of limb lengthening has fascinated me. And one of the more interesting applications is it clearly audible at the back? Fine. Is the treatment of achondroplasia. Now, achondroplasia, as you know, is one of the commonest forms of short-limbed dwarfism. This picture here shows, taken incidentally in India by a British Army officer, army surgeon, shows the different forms of dwarfism. This is an achondroplastic dwarf, and as opposed to this is taken somewhere in the 1850s. So these are other forms of dwarfism. The achondroplastic dwarfism is, in a sense, is another picture from a textbook which shows the different forms. And this is the achondroplastic dwarf. So they are the ones who are most amenable to some kind of, treatment that we can give. This is a rather large incidence. The trunk is normal. They are, if you were to liken them, to dog lovers especially, they are akin to a dachshund. A dachshund has an elongated spine, and if you could make a dachshund sit up in a chair, it wouldn't be any different. So achondroplastic dwarfs, if they sit on a chair, you can't make them out. But when they stand, they've got short limbs, short upper extremities. The upper segment to lower segment ratio, which should be 1:1.1. So the lower extremities from the pubic symphysis below should be 10% more. They are only at about 60%. So these are the typical facial features. They have, you can't miss them. You can't miss them also at birth. Sometimes pediatricians worry that it's a hydrocephalus caused by some other reason. But these are the common features in the face. You can't miss the faces, the frontal bossing, the depressed bridge of nose, poor mid-face, a large head. So, and then in the upper extremity, you have incomplete extension of the elbows. Typically, they can't extend. They have trifid hands. That's the separation of the fingers between the third and the fourth. And, they have short, stubby fingers. In the lower extremity, they have, in the lower extremity, they have obviously bow legs. They have upper tibial varus. They have reduced rotation of hips, and they can't sit cross-legged, many of them, because of the coxa breva, with high-riding trochanters. They have overlong fibulae, like so, which is a manifestation in many congenital anomalies. You have tibial hemimelias, which have fibular, but in achondroplasia, they're really long, and you have chevron-shaped metaphyses, and these are the typical features. However, the The thing to watch out for are the spine problems. They have, the really severe ones have foramen magnum stenosis, cervical and lumbar canal stenosis. These manifest in around the lumbar canal stenosis manifests around the 3rd decade. The cervical canal stenosis and foramen magnum stenosis, if seen they can be seen early, and they have upgoing Babinski, they have an upgoing plantar. And probably these are the ones you don't really want to do lengthenings in. Because of the short upper extremities, they can't reach down for personal hygiene, and as a result of having to bend, they develop dorsal kyphosis, and they have a compensatory lumbar hyperlordosis, which doesn't help the cause of lumbar canal stenosis, which exaggerates and increases it. So much about the clinical manifestations. In our society, of course, different societies have different ways of looking at dwarfs. In the Indian mythology, we have had the dwarf in an exalted position. This is the Vamana avatar of Lord Vishnu, who is depicted sometimes as a child, sometimes in some versions of the mythical story as a dwarf, in which he goes to the court of a tyrannical king, Bali, who is known to be magnanimous and yet tyrannical. And he asks him for a very small thing. He says, I'll give you what you want. So he says, I only want 3 steps. And the first step, the Lord Vishnu conquers the heavens. In the second step, he conquers the earth. And in the third step, he has nowhere to go. So he asks the king, where should I put my third step? So the king says, all right, now I have recognized you. You are the Lord and Master of the universe. You have to put your foot on my head. And that's what he does, and annihilates this demon king. That's the mythology. And various cultures have different ones. In our popular culture, there was this movie called Appu Raja, which really caught everybody's imagination, in which Kamal Hassan played a dwarf. So while these are positive aspects about dwarfism in culture, the reality of their day-to-day life is not so pleasant, and not so, in a society which doesn't have the ability to care to such an extent for the disabled or the differently abled. We have issues of functional impairment. All the functional ergonomics in society, such as utilities, buses, trains, electrical switches, handles, the heights of chairs, the heights of the commodes, which are standardized by ergonomically in all societies, are not befitting of these, and they face great difficulties. And worst of all, they do face a lot of ostracism and even cruelty as young children. So limb lengthening, to perform limb lengthening, to be able to make them look a little more like us and a little less different, is certainly a way of not only cosmetic lengthening but also of functionally enabling them to live in society. So my experience dates back to 1990. This young child, very close from here, from Bangalore, first came to me. This typical features. She was only 3'11". They don't normally grow beyond 4'1" if on the higher side, and they have their own growth charts which you can figure out how much they're going to grow. So we started by doing double level tibia lengthening. When they come later to us, that's the best way we can deal with it. And I did have my share of the usual teething difficulties. She had a transient lateral popliteal palsy, which we fortunately detected immediately, so we stopped the lengthening. It consolidated, the nerve recovered, then we did a repeat osteotomy and equalized her limb lengths, and she got a very reasonable 14 centimeters of height gain in something like 13 months. And this is a very happy and young surgeon with more hair in 1991. Well, we now know the genetic basis of this disease. This looks like a lot of Greek, Latin mumbo and jumbo, but this is, the younger ones could. This is the FGFR3 gene, the fibroblastic growth factor receptor 3 gene, in which you have a substitution of glycine by arginine at this location. So what it does is it delays the maturation of the chondrocytes in the hypertrophic zone of the physis. So the physis, they really don't mature. The large chondrocytes don't mature and come down into the meta and diaphysis to elongate the long bones. So you have a reduced longitudinal growth of the bone, but the length of all the soft tissues in the limb are destined to be normal. The genes responsible for muscle, nerve, blood vessel length, aponeurosis fascia length are all normal. So therefore you have a situation because of this uniquely that you may experience less difficulties in performing lengthening. So among other things, we believe that age is something that you can make use of judiciously. It will be a recurring theme in some of my talks, and when possible and when the parents are agreeable, within limits, we like to begin early, and we have a lot of success and reason to believe that's probably the way to go. This is a 5-year-old child, and we started with bilateral tibia lengthening, like so. She did have the same problem, but we detected it early, which is what's important. And so we stopped in time, took care of the issue, and here she is now at the end. You can see very good ankle dorsiflexion, so she recovered. In our entire series, we have had 4 neuropraxias, all of them recovered. We have had no permanent deficits. And we are very careful to judge them for their spinal cord issues, and we don't like to take on those who have even hidden or incipient canal stenosis. Then she went on to develop, we gave her humerus lengthening of about 9 centimeters to equalize the proportions between the upper and the lower extremities, also so important for personal hygiene. And then finally, she at a late stage, she did get cross lengthening, a second lengthening of the tibia, which yielded only 4 centimeters, to finally give her 33 centimeters of overall increase. And this girl was she became 4'11". This girl is a vivacious radio jockey for a while. She's happily married, and she's blessed with a baby girl, and she does send me photographs every year. She's really integrated well into society. So this is probably the best reason I feel that we can do this. So let's look at some of the strategies we can use depending upon when the patients come to us. We can do bilateral tibia lengthening followed by bilateral femoral. If they come to us at specific ages, we talk to the parents, we try to find out what are their goals, and if they come at the age of 8 or 9 like this, then we try and do the maximum amount of length possible. Here in this child, we chose to use the Ilizarov fixator. Notice the foot frames, because when we go beyond a point, the tendo-Achilles cannon does become tight, and you can prevent an ankle equinus. You can loosen the connections and allow the mobility of the ankle joint. And she went on to get a good 11 centimeters of length. Like so, she consolidated well. Even though it looks like it's in valgus, it's not. She has got straight limbs. And after a couple of years, she went ahead and we did, using an LRS fixator. We can use LRS frequently in the femur to good effect, especially if it's bilateral. We're taking due care to ensure that there is good knee range of motion. She got 10 centimeters. And here she is. She's become a short normal, and she's now entered medical school. The care that's taken during the lengthening is essential in making sure that the function doesn't suffer. And though it's a trade-off in terms of the amount of time they spend, the kind of confidence that they develop and the kind of push that it gives them for later life is so much more better. The advantage of starting early, I wanted to point out, is that you can do a second lengthening, and if they've really come early, you can perhaps do a third lengthening. But if they come to you at the age of 15, like this young lad, he came to us at the age of 12. He was already weighing 75 kilograms, and then they have this issue, many issues crop up, and I'm sure you'll understand this. I just want to regale you with the story of this. This child went on to, double level tibia lengthening. He got a good 15 centimeters, but it was very hard for his parents to control him. He was from Kuwait, and he went back home after the distraction, and his father invited me once. He lured me with an economy class ticket to Kuwait, and I got to spend 2 days in the desert state. And much to my dismay, I found out that part of the deal was I was supposed to do his dressing, because he wasn't allowing his father or the attendants to perform the dressing. And in the Middle East, there are these, I'm sorry about this, there are many mosques all over the place. And so I hope not to offend sensibilities, it's just very funny. Every hour or so, there is the muezzin calling out the Lord's name. So, the one dressing that I had to perform lasted for 4 Allahu Akbars. I apologize for any, but it took 4 hours. So they're really obstinate, they're difficult to manage, these children, and then what happens is, because it takes so long and they're obstinate, they don't want to go through anything again. So while he did get 15 centimeters, he did do well for his age at that time. Because of the reluctance, this is how he looks like as an adult, and certainly doesn't, though he's confident, he's an intelligent, confident, he's an engineer, it doesn't really help them. One of the other issues is facial features. One of the things we've discovered is, and this is what I've of course learned from the works from the Kurgan Institute, is that their facial features can improve if we start treatment early. They can get an improvement in their length and other things. So there are various reasons, and we do like to judiciously do this. When they come to us early, we do like to start with them. Of course, we try to find out what is the attitude of the parents and how is the child. Though we can't do the PEDS QL, we can't do the quality of life questionnaires on such young children, we do try in our own way to judge, and we do reject many people. We don't like to perform lengthening in many children and parents who are apprehensive. So when they do start early, they do stand to benefit like so, and it gives them a chance much later in life. They do adapt to the fixator rather well, and it helps. Like this child had a doggy with her all the time, so that helps. Having other children like themselves and having support really helps, and then they can, go ahead and have some more. So the question arises is, if you look at the literature, how much to lengthen? And if you look at the literature, you find some of the recent literature on achondroplasia, this reported a large number of complications. And when I went into the depth of the matter and I asked the author personally at one of the meetings, he said that yes, we decided to perform 10 centimeters of lengthening. And they had, so as opposed to that, from the very beginning, my philosophy has been, you do the maximum safe possible, that you monitor the patient, do not look at a predefined number, don't look at a target that you want to set for yourself. You look at the situation, go by the seat of your pants, go by how the patient is coping with the lengthening, how the regenerate is forming. Is it an atrophic regenerate? Then you cannot try to do more. You monitor the process, monitor the nerve and joint function, rather than deciding, and this is what I was told by one of the surgeons who has got many articles in the literature, that that there were 30% refracture rates in femoral lengthening. You know who I'm referring to, with due respect. And I came to know that they decide that we are going to lengthen all femora to 10 centimeters. So I'm not sure that's a smart thing to do. You have to go, you see how it goes, check for the tightness of the tendo-achilles in tibia lengthening, check for hamstring tightness, check for the quality of the regenerate, check for comfort levels of the patient. Is he doing fine? Is he ambulating well? And then decide to stop much earlier if you are not meeting. So we did, in our series, we did on an average 63% in the tibia, just about 50% in the femur. They did find in the literature more complications beyond 50%, and about 50 in the humerus. And the amount of lengthening ranged from 7 to 17 in the tibia and femur, and the humerus very standard 8 to 10 centimeters, which is enough. Is just the right balance between achieving the intended goal and not running into difficulties. And these are the kind of external fixation indices that we came up with, approximately a month per centimeter in all of them, which is what one should aim to keep it. If you're running into difficulties and if it's taking too long, then you're not doing something right, so you better stop early. So, we haven't had the need for stimulating the regenerate, and we haven't had regenerate fracture as opposed to 30% in one series which was reported in the JBJS. But we've had our share of tibia lengthening, premature consolidations in the femur as well as in the tibia. We've had, as I said, 4 neurapraxias which completely recovered, and surprisingly we have had a small amount of leg length discrepancy remaining for various reasons. One of the children who started at the age of 9 years, at his second lengthening, we knew that his femur went into consolidation and he needed 1.5 centimeters, and he simply refused a new surgery. So this is one of the manifestations of obstinacy, even though his parents told him, and he's an engineer today, he's still got the discrepancy, and he's coping with it, so we are fine, and everybody's happy with that. So we've had an anterior subluxation of the tibia in one very large lengthening, and we've had, in 5% cases, loss of range of motion. Axial deviations were also present. This is the main problem, and I'll show you one such problem and how we solved it. This is a doctor's daughter. We started with cross lengthening because they were sure they wanted to go ahead and do both the femur and tibia. So perhaps we thought this is a way to go. She got 12.5 centimeters in 2 level lengthenings in the tibia, about 9 or 10 in the femur. And here she's looking pretty good. Then the humerus lengthening she got. And she also had a rhinoplasty done by a friend, and scar revisions, etc., which really set her up for a good life. What she did develop was a lot of valgus in the tibia, and I had to correct on the right side with an LRS fixator. I had to do an osteotomy, and I used guided growth on the opposite side to achieve deformity correction, to give her very good and equal lengths and eventually a good result. So she had a lot of these scars revised since then, I'm told, and she is very well into her medical school and is reasonably happy. So probably a few more examples. This young lady from this state here who came to us pretty late, and very surprisingly she had she gained a lot of length. We did start with the LRS in the tibia, but my experience is not good. I converted it to the Ilizarov, and she went on to develop a lot of lengthening. She developed some heterotopic ossification at the pin sites, but it didn't really bother her. She developed an anterior subluxation, which we corrected with the frame in the femur. It was corrected, but she does have a loss of the last 50 degrees of flexion. However, she has gained dramatic amounts of length, which is almost 27 centimeters, and is very happy with the result. So we do have to treat with, I've shown you some of the complications I have treated in my own cases. When you do extensive lengthening, you can run into difficulties. This is somebody else has done this, young lad with a different form of dwarfism, a lot of valgus, and in the ankle as well. And you can see the high riding fibula, the fibula is subluxated. This is written up in the literature. It can happen if you're not careful. So this is how we solved. You can notice the discrepancy. So we fixed the foot. We translated it, brought the fibula down gradually, and we fixed it like so with screws after the regenerate had formed, solved the ankle valgus, and then he had this significant, I have now a series of 1.5 dozen lengthening malunions that I have treated. This is a common problem, valgus and procurvatum. This is valgus 14 degrees, procurvatum of 26. You can analyze it using the graphic method. The foot is, you're looking down at the foot, and you draw the fibula, the tibia over here, and this is the medial side on the right foot, the lateral side, and you can draw this. 26 degrees of procurvatum is 26 mm, 14 degrees of valgus is over here, apex medially. You complete this rectangle. This shows you the plane of the deformity. This is the concavity, and I choose to do a neutral wedge correction. That's angulation translation. So this is where you place the hinges. So you can get a very nice correction by doing this osteotomy like so over here, and he ended up with equal leg lengths and no deformity in the end. There's also like so. There's also another young lad who had this lengthening done at a very famous center, but he had a lot of lengthening. This is one of the things that happens when you, sometimes the patients get carried away, I must admit. I've shown you instances, or they simply don't get it right. They lengthen a lot, they get very happy, and he developed this. So what he has here, this is not the knee joint. This is the procurvatum and the valgus in the upper tibia. You notice over here, this is what looks like the knee, but it is not. And a lot of length he got with this uncorrected. So you need a lot of stability to prevent these deformities. You need to watch them. So we did an osteotomy correction like so, and took care of the problem for him. He aspired to be a photographer, and like him, we hope to change many of these people's lives. And I thank you so much for your attention.
Thank you very much, sir. We'll have the questions at the afternoon at the end of the session. Now we'll listen to a novel technique in limb lengthening by Dr. Ruta Kulkarni, the slotted plate technique for limb lengthening.
So actually, I'm going to talk about limb lengthening over a plate. In the morning, we heard a very lucid talk from Dr. Gubin about future of Ilizarov. So I can say that limb lengthening has really come a long way from pure classical Ilizarov to self-lengthening nail, fully computerized microchip operated self-lengthening nail. And in this path of progress, there are very important landmarks. Lengthening over nail, nailing and plating at the end of lengthening are few important ones, and of course, lengthening over plate. When lengthening over nail came in vogue, everybody ran after it, including me, because of its advantages like dramatically reduced fixator time and protection of the regenerate even after removal of fixator, prevention of refracture. But the initial enthusiasm faded away because of disastrous complication of intramedullary infection. There are various literature supports giving up to 22% of intramedullary infection rate with this technique. So we thought of using a plate along with external fixator, and this technique of lengthening over a plate was born. If you compare the lengthening over plate technique with lengthening over nail, actually LOP wins hands down. There are many problems with LON. It is technically very demanding. You have to put the shank pins, especially in proximal femur, very meticulously away from the nail. The operative time is huge. You get exposed to a lot of radiations. Then, as I've mentioned already, there is very high intramedullary infection rate with this technique. It is difficult or sometimes impossible to do it in children. Then one additional incision is required for the nail entry, and all the possible complications of reaming and intramedullary nailing are associated with this technique. Whereas LOP is technically quite easy. It has very low or almost no intramedullary infection rate. It can be used safely in children. No additional incision is required. We use the same incision of corticotomy to insert the plate. Nailing and plating at the end of lengthening is also quite popular, but again, in these techniques also, there is very high risk of infection because almost always we have pin tract infections. So those can spread into the bone. And of course, one additional surgery is required. We have done lengthening with this innovative technique in 27 patients with varied etiologies. The age ranged actually from 5 years to 35 years. We have done almost in tibia, only 2 femur we have done, and used Ilizarov fixator in all except one LRS. So actually even the plate has undergone evolution. The initial plate that we used was just a plain simple LCDCP 4.5. But from that we have graduated to a new slotted plate. The slotted plate looks like this. I'll explain why we have switched off to the slotted plate. The length of the plate is equal to the amount of desired lengthening to be done. So the new slotted plate is available in 4 sizes, 4, 5, 6, and 7 centimeter slot. It's a 4.5 locking plate actually. So the technique goes like this. First we cut the fibula. Then we put the plate on the tibia, and under C-arm, we mark the site of corticotomy. At the site of corticotomy, we make multiple drill holes. Actually, first we take a vertical incision at the corticotomy site. It is slightly larger than the usual corticotomy incision. It's about 1.5 centimeter long. Then at the site of corticotomy, we make multiple drill holes, and through this incision, we slide the plate subcutaneously, extraperiostally on the medial surface of tibia, which is quite easy, first distally and then proximally. Then we put 3 screws in the proximal holes of plate and then apply fixator. This is a 3-ring construct, but the middle ring is empty. We put 4 wires in proximal ring and 2 wires under shank spin on the distal ring, and then complete the corticotomy. Initially, the problem which we had was plate prominence because the plate left the bone during lengthening, and the bone also bent in procurvatum. So to overcome this difficulty, we developed this slotted plate. So we put a screw in the slot, and that screw goes in the distal fragment and slides in the slot during lengthening. There are many advantages of this slotted plate. The screw holds the bone flush to the plate. It avoids deformity of the regenerate, and it gives extra support to the regenerate. So this is the animation. First we start with cutting the fibula. Then we slide the plate on the medial surface. Put 3 screws. Before that, we make multiple drill holes at the desired site of corticotomy. Mark the corticotomy is between the last screw and the slot. We apply the fixator. Complete the corticotomy. Then insert the screw in the slot. It is just distal to the corticotomy. So start your lengthening. During lengthening, it slides. At the end of the lengthening, put 3 more screws in the distal fragment and remove the fixator. Your consolidation is taken care of with this plate. Actually, we also put a syndesmotic screw in the fibula to tibia to prevent proximal migration of the fibula till the fibular regenerate ossifies. So the post-op protocol, distraction is started after 5 to 7 days. Wet bearing is allowed throughout. After removal of the fixator, we allow guarded wet bearing. Few cases, a case of old infantile septic hip, a 9-year-old boy with 3 centimeters of shortening. I did a tibial lengthening. This was his limb before and after. He is due for a pelvic support osteotomy a few years later. A case of non-union of subtrochanteric fracture since a very long time in a 16-year-old girl. So her non-union was united, but her femur was very short and osteoporotic, so I did 4 centimeter tibial lengthening over a slotted plate. Fixator was off within about 40 to 50 days. I never ever had any problem with regeneration with this technique. The regenerate is always excellent. So that's her limb before, and that's how she's walking afterwards. This was treated elsewhere, lot of overlapping, 4 centimeters of shortening. Again, in this man, I did a tibial lengthening over a slotted plate. See, at the time of fixator removal, I did not see a good regeneration there. But to my surprise, it appeared within few months. The regeneration was excellent. This was a case of chronic osteomyelitis leading to a very severe deformity. I corrected his deformity in femur and lengthened him 3 centimeters, but the bone was very bad, so I lengthen the remaining amount in tibia over a slotted plate. And that's the regenerate. You can see I put this screw for about 6 to 8 weeks to prevent proximal migration of fibula and then remove it under local anesthesia. See the good amount of regenerate. Usually I don't remove the plate before 1.5 years. Few cases in femur, actually only 2 cases of femur. This is a congenital short femur syndrome, a very difficult condition to lengthen. She had 6 centimeters of shortening and I did it over a plate. And that's her clinical result. That's her X-ray. Minimal rate of complication actually. This is an adult girl, 17-year-old girl actually, with congenital short femur syndrome. She also had a valgus deformity in her distal femur. She had 6 centimeters of shortening. I corrected her deformity acutely and did lengthening over a plate. I had to fix across the knee joint to prevent subluxation of knee joint. And that's the lengthening. That's her. And that's after removal. Initially, I used only a unicortical screw in the slot, thinking that if I use a bicortical screw, it may not slide freely. But in this girl, I have used a bicortical screw, and it is sliding very well. So henceforth, mostly I'll be using a bicortical screw, which will add more to the stability. So I have studied my results with these parameters: lengthening achieved, X-fix index, consolidation index, and complications. I had mean 4.4 centimeters of lengthening. The X-fix index was just 60 days. X-fix duration, I'm sorry. The mean X-fix index was 16 days. Mean consolidation index was just 33 days. I had few complications like pin tract infection, screw site infection only in one, and TA contracture in one. The plate prominence and procurvatum I had before I started using slotted plate, none with the slotted plate. We have published this as original article in Indian Journal of Orthopedics. Soon we'll be coming out with the paper on comparative results of lengthening over plate and lengthening over nail. I have also published it as a technique in Journal of Maharashtra Orthopedic Association. So to conclude, this is quite acceptable to patients. It is way simpler, it has very less complications, and cheaper. So I can now say that it is superior to lengthening over nail, but I'll come out with the paper very soon. Thank you for your kind attention.
Thank you, ma'am, for sharing the novel technique.